Hello. You might see me shuffling a lot. It's to keep my feet warm. I think that's the coldest part of me right now. I'm really happy to be really happy to have been invited here, and really grateful for the effort that the people, the assemblymen, the supervisors have put into putting this together, because it's so important. And it's hard to imagine that, you worry that sometimes when people say that this might be the most important thing of our lives in terms of the times we are in now and the decisions we make. And, people have said that often, kind of looking over history. And I do feel that is the case now. And sometimes I worry that maybe it's not true, but I really do think it is true. I think the forces we're facing and that are colliding are really that critical for the future of humanity and what that's supposed to look like. So if you could maybe bring up the slides just so I know they're there even. Okay, so I'm speaking for myself and not on behalf of UCLA. And what's the next? And I'll be talking about the science supporting early outpatient treatment for COVID-19. Okay. And then you can go back to me now. I want to see me on the video. you, would you thank you, thanks. Okay. So I thought about, what could I say that would be helpful to the audience today? And as I was thinking about it, I thought that one maybe unifying theme might be the idea to reassure the people out there who have some doubts about their position in the face of total opposition on network television, out of the mouths of health officials. So the notion, convey the notion that you are not crazy, right? It is easy to wonder whether you're crazy when you're saying one thing and everyone else out there, everyone on CNN, everyone on NBC, the New York Times, Washington Post, everyone out there is saying something different. And you wonder, and some of us have undoubtedly, am I crazy? Could I be wrong? Why is everyone saying something different from what I'm feeling is the right way to think about these problems? And so that's where the focus of my talk today is going to be on. Just reassurance and evidence that you're not crazy. And interestingly, we've talked about the policies. We did that this morning with the assemblyman. Dr. Badakar has talked about lockdown policies. And there are actually very analogous themes that run across all of those, that are shared by all of those in this pandemic. So a piece of that is the science, and in particular, the science of early outpatient treatment. Something that has not been fun to watch during this pandemic is the weaponization of science. And that's what's happened with science in this pandemic. And it's been something, and it stretches across many controversial areas, from the effect of lockdowns in terms of whatever effect they have on health, to the role that children play in the transmission of COVID-19. There are debates about the effectiveness of masks and the role of them, and there are debates. You wouldn't know it, again, listening to the network television anchors, but there's debate about the role of outpatient therapy. Can you actually treat this thing before people get really, really sick? And it's been really challenging, the science debates, for regular people. And the reason it's been really challenging for the regular population is because COVID-19 manages to bridge multiple domains. So there's the science domain in terms of what exactly is happening physiologically with the body, what's happening with patients, why are people getting sick and dying, and some people were not having any symptoms whatsoever. There is the epidemiology component, and my friend Dr. Jay Bhattacharya has talked about that. The fact, as did Supervisor Hewitt, about the fact that, in fact, the actual burden of disease was hiding in the background, and it was really the burden was placed on all the positive cases, but it was really hiding amongst all the people out there who got it, got over it, and were basically never picked up. And there's the policy piece. How do you balance different interests, different risks, different trade-offs? How do you make decisions that that lead to good outcomes for society? So it's been challenging, and it's hard for people who don't have a background. If you don't have a background in enough of these places, it's easy to feel like, I probably have something wrong. What they're saying on television or in the New York Times or Washington Post, it's probably correct. There's just so many pieces of this thing. Well, fortunately, you do have friends, and some of those friends are up here. So in terms of outpatient therapy, like whether people can actually do anything at home to avoid getting sick from COVID-19, what you usually hear from most of the people that get airtime is that, that studies have shown that, fill in the blank, whatever treatment it is, whether people are talking about zinc or, vitamin D or hydroxychloroquine or whatever else, doesn't work. The studies show it doesn't work. And that's, it's kind of a concise statement. Such and such doesn't work, period, put a pin in it, done, right? And this morning, the assemblyman mentioned that when the governor says that he's listening to the science, what it really means, and it actually is true for everyone, not just a governor, is that he or she is listening to a particular group of scientists that that have some shared opinion. With treatment for COVID-19 and the studies that show that such and such fill in the blank doesn't work, it's actually the same exact thing. So the reality, and this is a fact, which for whatever just terrible reason, you can't have an objective conversation about or hear more than one perspective on the news, is that some studies show that some things don't work, but some studies definitely show that some of these same drugs work. So one of the things that has bothered me and a lot of other people is that if you do have evidence that something works and you have evidence that something doesn't work, the answer isn't to just stick in, just kind of sit down and get comfortable in the area of it doesn't work. Like, the answer is to look more broadly, think about how we can learn more, get more, gain more precision, and at the very least allow doctors who have expertise with some of the medications that they believe work to use them, as Dr. Farid has discussed, right, and other doctors like him. So with that said, the next thing I'll do is just walk through a few studies of things that for which there's evidence that they work, even though there's debate. And for crying out loud, fortunately I'm at low risk of getting ill from COVID-19. But if I were 30 years older and had diabetes or was obese, I don't know how in heaven's name I would have this information and get diagnosed and go home and wait, and hope for the best. That's completely nuts, right? The rational thing to do is, it's nuts. Even though, the speakers on CNN want to tell you that that's the right thing to do, just go home and quarantine. That's crazy. If you have risk factors, that is completely crazy. And the right thing to do is, if there are medications that potentially could be helpful, have evidence for efficacy, obviously that's what, definitely treat me. I'm not going to go home and just wait and hope that, I wait out the clock and don't turn out to be one of those people that 5 days in is short of breath and going to the hospital with COVID pneumonia. It's completely nuts. We should be treating people that are high risk with the evidence that we have. So I'll just share just very highlights of some of that evidence. And I just put some, you can put the slides up now. And I just created some slides that just to show you that I understand. I know that most of the people in the audience aren't scientists, but when when your friends say no, that treatment doesn't work, here I want you to have a resource to point them to say, hey, there actually is evidence that it works. Maybe it doesn't work in reality, but there is evidence that it works, and that's something. So this is an editorial. I've written like 8 or 9 of them in the Wall Street Journal now during this pandemic. This one's called "Too Much Caution is Killing COVID Patients," and basically, this discussion that we've had now, I basically go through in that article, which is that there's evidence of efficacy, there's uncertainty. Let's get more data. And in the meantime, why don't we, get more data by treating people? Like, that's one good way to get data. So if you go to the next slide, please. One of these medications is fluvoxamine. And we have someone else who's going to talk a little bit more about that. I started with this particular medication. It actually has, of all the things out there so far, it has sort of almost the lowest amount of evidence, but it's also the highest quality. So this was published in the Journal of the American Medical Association, which is one of the leading medical journals in the world, and arguably the leading medical journal. Arguably the leading medical journal in this country. It or the New England Journal of Medicine, and basically, this was a randomized clinical trial. It was well executed. It wasn't huge. I think it had somewhere around 160 patients. And they found that if you treated people with fluvoxamine early, there was a benefit in terms of their prevention from getting worse, from having clinical deterioration. So it very clearly demonstrated that. Again, it was a smaller study. So another randomized controlled trial that's larger is underway now, testing the same drug. But this is and should be an option for people to consider with their doctors if they have COVID-19 and have risk factors. And then the next slide, please. So this is a study that's on a preprint server of ivermectin. So many people probably saw the viral Senate testimony of Dr. Pierre Corey several weeks ago about early outpatient therapy that Senator Ron Johnson held. And this is another medication that for which there are multiple randomized clinical trials. And by the way, that's all I'll talk about is randomized clinical trials, only because they're sort of the least controversial in terms of study models. And there have been multiple randomized clinical trials of ivermectin that have shown a benefit for patients with COVID-19 in terms of preventing serious illness. So the catch here, so with fluvoxamine, I'd mentioned that the shortcoming is at this point, there's not a lot of evidence. There are very few studies. It looks good, but there are few studies. With ivermectin, there are more studies. The drawback there is that many of those studies haven't been performed in countries that we're sort of, as a scientific community, more comfortable accepting evidence from. So they've been more, countries in the Middle East, countries in developing countries, not like countries like Europe, or the United States, of course, where we have more shared culture and might be more accepting of the findings. But there actually also is data that's non-randomized. That's kind of, for example, Pierre Corey, in the patients he's treated in the hospital, they've done better with ivermectin, and that's been published in a really good American journal called Chest. And so there is evidence for its effectiveness. And for fun, I was exchanging emails with Pierre, and I'll read you what he wrote me. So Pierre wrote me, we were both kind of griping about how medicine's lost its mind, and you can't even have debates anymore about treating patients or do what you think is best for treating patients. And he wrote, "This saga in medicine has been just a mess. The world has gone mad, or I have, or both. Don't worry, ivermectin is going to end the pandemic, I promise." So that's Pierre, sharing how his take on that. And before I go on to the next medication, another thing that came up today that is also applicable to this issue of outpatient therapy. Someone mentioned earlier this idea that I think maybe one of the assemblymen, that people need to fall in line. And it's kind of the same thing that's happening here with medications, where the things that are not mainstream, talking about ivermectin, talking about fluvoxamine, et cetera, are often kind of stomped on and kind of stamped out. So could you show the next slide, please? Okay, so this slide is what we call a meta-analysis, the results of a meta-analysis of randomized controlled trials of hydroxychloroquine in COVID-19. So obviously, man, everyone's heard about this medication by now, and Dr. Farid has used it really with outstanding results for his patients. And I and some other colleagues did a meta-analysis that we'll revise because we've gotten some additional data about. But basically, this meta-analysis showed evidence for a benefit when it was used early. And one of the things you see in the studies is that oftentimes hydroxychloroquine was used late. And something that is like super true for viral illnesses is that it's better to treat early. And it's not just COVID-19. It's true for influenza, treating early. If you treat late, it's not to be beneficial. It's true for several different viral infections. So that was basically what that study showed, and that study is under review. And then could you show the next slide, please? Okay. And then this is just one other randomized trial of brohexine, which is sort of, it's like a decongestant. This one's been published, and again, this was outpatient therapy, and they found, the researchers found a benefit. The study, I think, was maybe in Iran, but yeah, so more evidence, right? So another medication, this was a randomized trial, found to be beneficial. Could you show the next slide, please? And right after this one, I think. Okay, all right, cool. Okay, so this one, I to really hammer home the point of early treatment being an important component. So you guys have probably heard of convalescent plasma. So convalescent plasma is like sort of basically taking the antibodies from people who have recovered from COVID-19 and using them to treat people who actively have the disease. So convalescent plasma treatment, it's a very old treatment. It's something that has been done in medical care for a long time. And that study I just showed you was published in the New England Journal of Medicine. So that study found that it wasn't beneficial. So 4 days ago, the New England Journal of Medicine published another study of convalescent plasma and found that it was beneficial. The biggest difference between the two studies is that the one I just showed you, that everyone kind of, concluded that it wasn't beneficial from, treated patients on average something like 8 days after they had symptoms, 8 or 10 days after they had symptoms. The one that was published a few days ago in the New England Journal of Medicine treated patients within 3 days of symptoms, and they found a big benefit. So this idea that early treatment, which is like, is probably been around, is undoubtedly been around before I was born. I mean, this is not some new science or some, it didn't require some Einstein-like insights. It's a very simple and basic idea. Is really being shown to be something that is important and makes a difference between whether high-risk patients do well or not when they're infected with COVID-19. And it's like more people are kind of getting on board now, But this is old knowledge, and one wonders, why has it taken so long for my colleagues, for our scientific community to, to be sensible about, about science in the treatment of COVID-19. So that's about it for the studies, and and then just some parting words along the same theme about kind of what's been happening with science. So hopefully, I hope that I've been successful in convincing you that the syndrome of wondering whether you're crazy or not is a treatable syndrome, and it's treatable with you holding on to the fact that there is data to support that lockdowns aren't necessarily a good thing, and that you actually can treat this condition early. And it is okay to have an opinion that is different from what we hear, again, in all the major news, in most of the major newspapers and television news channels. And one of the reasons that our scientific community, and I discussed it in that Wall Street Journal our editorial, has not been more vocal, has been the use of shame as a tool. So one of the most damaging things you can do to any scientist is accuse him or her of a doctor, is accuse him or her of not being evidence-based. Like, that's one of the most damning accusations that you can accuse someone of, like, basically calling them a quack or something like that. And and that kind of accusation functions through the channel of shame. And it's the same channel that's used to sort of manipulate people into feeling like they should stay at home, into feeling like they should wear a mask when there's no scientific basis for it. For example, when you're outside and not close to anyone, there's absolutely no scientific basis for it. But this sort of channel of shame is basically the most effective tool that that leaders and political leaders who have no love for humanity can use to elicit the behaviors that they are that they are trying to compel. And it's so important to for people like the people in this room to step beyond that and do what they think is right and say what they think is right despite those forces. Not only is it important for its own sake, but it also provides permission to other people who are kind of on the cusp but hesitant to sort of step out, drop the shame game, and stand for what they believe is right too. So it's good for us and it's good for everyone else to keep doing that.